Dear audience, in the next few minutes I would like to introduce you the topic of my PhD thesis entitled Optimization of Acute Pancreatitis Management. My name is Patoni Cristina. I am a resident in gastroenterology. I work at the military hospital in Bucharest, and this year I'm part of the translational medicine program with a scholarship offered by MOL Group. And my supervisors this year are Dr. Balinteros and Dr. Peter Hegieno. As a pancreatologist, my vision about acute pancreatitis is that we can decrease mortality and major complication rates by improving the management. For this, I would like to answer two specific clinical questions regarding acute pancreatitis treatment. The first project is entitled Anticoagulants Decrease Mortality and Major Complication Rates in Acute Pancreatitis. A few words about the background. Acute pancreatitis is an inflammatory disease, and as a consequence, it is associated with a vascular injury within the pancreas, activation of coagulation, and increased leukocyte rolling. Moreover, there is a close relationship between thromboembolic events and the severity, but the decision to initiate the anticoagulant treatment is hard and is challenging because of the often unpredictable course of acute pancreatitis, and because of the lack of the data and recommendations from the guidelines. With our graphical abstract, we wanted to emphasize what recent studies have shown about heparin, that besides the prevention of activation of the indirect coagulopathy pathway, it has the ability to bind the inflammatory cytokines and to reduce the inflammation and to suppress the activity of digestive enzymes. For this meta-analysis, we use the PICO framework, and our hypothesis is that anticoagulants, the administration of prophylactic anticoagulants is safe and improves the outcomes in acute pancreatitis. Here we have the PRISMA flowchart. The search was performed on 14 October on 3 databases. It retrieved almost 8,000 articles, and in the end we included 7 in the meta-analysis and 8 in the systematic review. Now I will start to show you some of the results. All of the studies included reported mortality as an outcome. 6 out of the 7 studies reported the use of low molecular weight heparin as therapy, and the population was represented by patients with moderately severe and severe acute pancreatitis mainly. As we can see, all studies report similar results in favor of anticoagulant treatment. And the RCT subgroup shows that anticoagulants lead to a 76% decrease in mortality rates. Highly related to the mortality is the multiple organ failure. Again, results are similar. In the RCT subgroup, we can see that the incidence of multiple organ failure is decreased by 76% by adding anticoagulant treatment. As for the need for endoscopic or surgery intervention, in the RCT subgroup, again, we have similar results, low heterogeneity, and our results show that by adding anticoagulant treatment, the need for intervention is reduced by half. The length of hospital stay in the anticoagulant group was shorter, with around 5 days. The strength of our study is that we have an increased level of evidence because we were able to perform subgroups only for RCTs for all our outcomes. We have a total number of patients of more than 200 patients for every outcome, and we have low heterogeneity in the RCT subgroups. Of course, we use the robust methodology. We have some limitations as well because we have a few low amount of data for the subgroup analysis for the moderately severe patients, and studies do not report the safety outcomes. To sum up, anticoagulants reduce major complication rates and mortality rates, and we should further investigate the mild pancreatitis cases as an implication for research, And we should report the safety outcomes such as bleeding and report the laboratory parameters. As for the status of this manuscript, it was submitted to the Alimentary Pharmacology and Therapeutics. And we had the opportunity to present our results to several international presentations, such as European Pancreatic Club meeting, and we will have an oral presentation to the United European Gastroenterology Week. Now let's move forward to the second project, entitled Safety of Early versus Late Endoscopic and Percutaneous Interventions in Infected Necrotizing Pancreatitis. Infected necrosis occurs in 40–70% of the cases of necrotizing pancreatitis, but since the introduction of the step-up approach, there is a debate in the literature regarding the optimal time of the drainage, since the European guidelines recommend the delayed intervention after the 4 weeks, but the American guidelines consider the early drainage even before 2 weeks for patients who are symptomatic or have infected necrosis. For this meta-analysis, we use as well the PICO framework, and our hypothesis was that postponed interventions are safer than early intervention in infected necrotizing pancreatitis. The search was performed at the end of March. It had 3 main concepts, and it was performed on 5 databases. After the duplication removal, we have more than 10,000 articles, and in the end, we included only 7 in the meta-analysis. I will start to show you some of the results. Regarding the mortality, we can see that mortality rates are similar between the early drainage and the delayed drainage, but results are not statistically significant since we have a small sample size and a low amount of studies included. For the new onset organ failure, also no significant differences were found in the early drainage compared with the delayed. Bleeding was also one of the outcomes we wanted to evaluate. Only 3 studies are included for this analysis, and data suggest again there is no significant differences between early and late drainage. As for the need for open surgery, we can see results are quite heterogeneous. In the RCT subgroup, we can see they report the results in favor of the early drainage, whereas for the cohorts, they report results in favor of the late drainage. But as an overall, we can see there are no significant differences for the need for open surgery. Length of hospital stay, we can see there is a tendency of being longer in the earlier drainage, but length of intensive care stay, no significant differences were found for our studies. The strength of this study is that this is the first meta-analysis to assess the differences between the late and the early drainage. And of course, we used as well the robust methodology. But the main limitation is that we have small sample sizes and low amount of studies included. We also performed the risk of bias using the ROB2 tool and the Robbins I for observational studies. As a quick overview, we plan to submit the second study at the end of September. Thank you for your attention, and I would like to end my presentation with the quote of Vincent van Gogh that great things are done by a series of small things brought together. And if there are any questions, I would be happy to answer.
Concerning the first study, have you looked at which anticoagulants are best to decrease the severity of pancreatitis? And I also have a question concerning the action of heparin on digestive enzyme activity, which struck me as interesting that it decreases digestive enzyme. Do you have any idea how this is carried out by heparin?
I mentioned that 6 out of the 7 studies included in the analysis report the low molecular weight heparin, and 5 of these report the enoxaparin. One of the studies that does not mention the type of anticoagulant. Of course, we wanted to see the different maybe type of results between the types of anticoagulants. Perhaps we will be able to do this in the future, since the Mayo Clinic, they are currently doing a study for the bigatron in acute pancreatitis. So for now, we can say that enoxaparin is safe and reduces mortality rates. For the second question, indeed, there are 2 studies that have shown that heparin reduces the digestive enzymes. For the detailed the mechanism behind this, I'm not quite sure.
Do they absorb? So, do they absorb the digestive enzymes? Because these are, well, can be high molecular weight heparins as well. So, can it be like a physical way of inactivation?
I haven't read something about this in detail, but I will try to find the explanation. Thank you.
Congratulations, Cristina. It was a very nice presentation. My question is, as regard of low molecular weight therapy in acute pancreatitis, did they mention if they used a full dose or just a preventive dose of low molecular weight heparin?
Thank you for the question. Yes, actually they used, in 3 of the studies, they used the prophylactic dose, and in other 3 they used the therapeutical dose. And we performed subgroups for this that show there are no significant differences between these 2 subgroups, so we can say that prophylactic anticoagulant is safe and has benefits instead of the therapeutic dose.
I have got a comment on your second project. From the Boxhorn study, which is the only randomized controlled trial in the topic, isn't it?
There are 2. There is one more.
One more.
Yes.
But from the Boxhorn, we learned that 40% of the patients who ended up randomized on the early drainage group eventually did not need drainage. So it makes a little bit difficult to interpret the results of your forest plots. And this is really just a comment that, you have to bear in mind that in the early group, you are potentially looking at 40% of the patients who had their procedure for no good reason, statistically speaking. So that's my only comment, but beautiful projects and congratulations.